Good evening, everybody. Welcome to our presentation on protecting my future, screening for cancer and cancer survivors. Really glad to have so many guests, and I'll introduce myself and our team. My name is David Fryer. I'm the director of the Cancer Survivorship programs at the USC Norris Comprehensive Cancer Center and at Children's Hospital Los Angeles. And as an oncologist who both takes care of patients who are newly diagnosed and also those in survivorship follow-up, it's very clear to me that the treatments that we use can sometimes cause undesired late effects, and one of those is having a subsequent type of cancer. And we aim to address that in our discussion today. I'm joined by four experts in this field. Jennifer Solomon, who is the coordinator for our cancer survivorship program at the USC Norris Comprehensive Cancer Center. Julie Culver, who is the director of genetic counseling in the cancer genetics program, and she's joined by her colleagues, Jacob Como, who is a senior cancer genetic counselor, and Becca Wagner, who is the cancer genetic counselor as well. So we're going to be going over several topics here that will be shown on a slide to come as far as the organization of the presentation goes, and we will be allowing enough time for questions and answers at the end. I'll just mention that the presentation is being recorded at the present time up to the questions and answers, and that's so that people can watch it later via a link. But at the question and answer period, when some of you may want to bring up questions that are of a more personal nature, the recording will be stopped and that will actually not be recorded. So without further ado, I'm going to ask the slides to be advanced, and Jennifer Solomon will give the first presentation.
All right, thank you. Thank you, Dr. Fryer. So a round of applause to you all. By attending this webinar, you've already done the first step in protecting your future. I'm Jennifer Solomon. Like Dr. Fryer said, I'm the nurse practitioner for the Cancer Survivorship program at Norris. And objectives, I will discuss the following: modifiable and non-modifiable cancer risk factors, cancer screening guidelines, strategies for cancer prevention for lung, colorectal, breast, prostate, cervical, endometrial, ovarian, and skin cancer. So quite a lot to get through. So positive facts about cancer. Cancer is no longer a death sentence. Some cancers are curable, and if not in most cases, cancer is treated as a chronic illness. 2, we have the power to try to prevent cancer with lifestyle modifications and screening. So based on CDC in 2021, the number one leading cause of death was actually heart disease, followed by cancer, then followed by COVID-19. So I'm going to start with lung cancer. Lung cancer risk factors: tobacco use, quantity and duration plays a role. Huge population at risk, 91 million former and current smokers, which is 37% of our population. 85 to 90% of lung cancer cases are from exposure to secondhand smoke, occupational exposure, radon, asbestos, air pollutants, etc. Radiation therapy to the chest. For never smokers, lung cancer in never smokers is actually more common among women. Lung cancer symptoms, if there are: early symptoms, cough, shortness of breath, or difficulty breathing. Late symptoms, hoarseness, hemoptysis, coughing blood, atelectasis, collapsed lung, pneumonia. Lung cancer screening. The gold standard for early detection for lung cancer is low-dose CT or computed tomography scanning. Lung cancer screening criteria. There's a criteria. You have to be between the ages of 50 to 80 years old, in fairly good health, and currently smoke or have quit smoking in the past 15 years, and have had at least 20-pack year smoking history. This is the number of packs of cigarettes per day multiplied by the number of years smoked. For example, someone who smoked 2 packs of cigarettes a day for 10 years, you do 2 times 10, which is 20. So that's a 20-pack year smoker. As does a person who has smoked 1 pack a day for 20 years, you would do 1 times 20, and that would be a 20-pack year smoker. Lung modifiable risk factors. Never smoke. And if you smoke, quit smoking now. Utilize available support resources to quit smoking. Example 1-800-NO-BUTS or 1-800-QUIT-NOW. Avoid secondhand smoke. Avoid exposure to asbestos. Avoid occupational exposures via OSHA guidelines for safe practice. Colorectal cancer. Colon and rectal cancer facts. Death rates have declined over the past 2 decades, reflecting early detection and treatment. There are no symptoms for early colorectal cancer. Hence, screening is vital to detect early stages. Colorectal cancer is a preventable cancer. Colorectal risk factors. Risk increases with age. About 90% are greater than age 50 years old. Personal or family history of colorectal cancer, personal or family history of polyps, personal history of chronic inflammatory bowel disease, ulcerative colitis, Crohn's disease, obesity, smoking, heavy alcohol consumption, diet high in red meat and processed meats. So people, get rid of the deli meats, okay? They're not good. Radiation therapy to the abdomen, pelvis. Colorectal cancer screening based on the American College of Gastroenterology in 2021 guidelines recommend start colorectal cancer screening in the average risk individual between the ages of 45 to 75 years old. The ACG recommends colonoscopy and FIT as the primary modalities for colorectal screening. Colorectal cancer screening for high-risk individuals. The ACG suggests for those individuals with first-degree relatives diagnosed with colorectal cancer or have had an advanced polyp before age 60 to initiate colorectal cancer screening with colonoscopy starting at age 40 or 10 years before the youngest affected relative. Consider genetic evaluation in individuals with familial colorectal cancer burden. Colorectal cancer screening, again, for high-risk individuals. Personal history of childhood, adolescent, or young adult cancer with a history of alkylating chemotherapy, even without radiation. Colonoscopy starts at age 35 or 10 years after age of chemotherapy, whichever occurs first, and continue every 5 years. If you've had history of radiation involving the abdomen or pelvis or lower spine, which is like XR radiation on the lumbar, sacral, or total body irradiation, regardless of dose with or without chemotherapy, colonoscopy actually starts even earlier at age 30 or 5 years after treatment, whichever occurs last, and continue every 5 years. Prevention of colon cancer. Diet, low in fat, high in fiber, avoid processed meats, limit red meats, vigorous physical exercise, avoid smoking. Polyp removal reduces risk of colon cancer by 80%. So people, get your colonoscopies. Breast cancer. Breast cancer risk factors. Starting your period at an early age or having late menopause. Family history of breast cancer. Genetic mutations in BRCA1 and BRCA2. High breast tissue density. African American women have higher risk of advanced breast cancer at earlier age. Recent or prolonged use of oral contraceptives or oral birth control. Obesity, postmenopause, physical inactivity, hormone replacement therapy, ionizing radiation, Hodgkin's mantle radiation, or chest thoracic radiation between the ages of 10 and 30 years old. Also alcohol use and any diagnosis of abnormal tissue in the breast. So breast cancer screening for an average individual. So starting at age 25, but less than age 40, clinical encounter, breast awareness, women know your breasts, okay? Know them, okay? So, and then starting at age 40 and above, annual screening mammogram. Consider supplemental screening. If you have dense breasts, ask your doctor for even an additional ultrasound. So breast cancer screening again for high-risk individuals. Annual screening mammogram with tomosynthesis to begin 10 years prior to when the youngest family member was diagnosed with breast cancer, but not prior to age 30 years. Okay, so so let's go for it. Those who received chest and thoracic radiation between the ages of 10 to 30 years old. So less than age 25, clinical encounter every 6 to 12 months. And again, know your breast awareness. But if you've had chest radiation and you're 25 years old and older, we're going to start with annual mammogram screening or begin 8 years after radiation, but not prior to age 25, and annual breast MRI with and without contrast. And you begin 8 years after radiation, but not prior to age 25 also. And some physicians actually alternate between mammogram and breast MRI, which is totally fine. So breast cancer prevention, pregnancy before age 20 reduces risk. Breastfeeding reduces risk. Exercising reduces risk. And a prophylactic mastectomy for women with strong family history of BRCA1 and BRCA2. Prostate cancer. The risk of developing prostate cancer increases with age, with exception. 1 in 10,000 men younger than age 40 are diagnosed with prostate cancer. But the usual 1 in 15 men in their 60s are diagnosed with the disease, more common. Race, ethnicity. African American men and Jamaican men of African descent have the highest incident rates in the world. Genetic familial, about 5 to 10% strong familial disposition with BRCA1 and BRCA2 gene mutations, BRCA and other inherited genetic mutations. Having a father or brother with prostate cancer may double a man's risk, especially if that relative was diagnosed before the age of 55. Diet international studies suggest saturated fats and obesity. So recommendations for early detection. Age 50 for men who are at average risk of prostate cancer and are expected to live at least 10 more years. Age 45 for men at higher risk of developing prostate cancer. This includes African American men and men who have a first-degree relative, father or brother, diagnosed with prostate cancer at an early age, younger than the age of 65. And age 40 for men at even higher risk, those with more than one first-degree relative who had prostate cancer at an early age. You would start at age 40. Prostate cancer screening is the prostate-specific antigen, the PSA blood test. Men who choose to be tested, who have a PSA of less than 25, may only need to be retested every 2 years. Screening should be done yearly for men who have a PSA level of 25 or greater. And then there's the digital rectal exam done by your provider. Cervical cancer. Okay. Smoking and cervical cancer. Okay, there is a correlation. Cigarette smoking and tobacco use have been identified as cofactors for squamous cell cervical cancer. Tobacco-specific carcinogen continin has been isolated from the cervical mucus and genital tracts of women who use tobacco or who have been exposed to secondhand smoke. HPV infection, human papillomavirus. A large majority of cervical cancer, more than 95%, is due to the human papillomavirus. Most sexually active women and men will be infected at some point in their lives, and some may be repeatedly infected. More than 90% of the infected populations actually eventually clear out the infection. Some people don't even know they ever had HPV. Okay, but cervical cancer screening. So there are 2 tests. There's the HPV test, which only checks for the HPV virus, and there's the PAP test that checks for abnormal cells from the cervix. So 2020 American Cancer Society, basically this chart shows that starting at age in the middle, age 25 to 65, you can actually get the HPV test every 5 years, which is preferred, or the HPV and PAP co-test every 5 years, which is acceptable, and the PAP test every 3 years, which is acceptable. If you are a woman who is 65 and older and has had series of all normal tests, then you no longer have to get screened for it. So cervical cancer prevention, vaccine is the main prevention. CDC recommends HPV vaccination for all preteens, including boys and girls, and they can receive the vaccination starting at age 9 to 12 years old. Everyone else through the age up to 26 years old, if not already vaccinated. Now, vaccination is not recommended for everyone older than age 26. However, some adults do choose to, between the ages of 27 and 45 years, who have not been already vaccinated, and they may, get the HPV vaccine after speaking with their healthcare provider about risk for new HPV infections and the possible the benefits of the vaccination. Um, and also HPV vaccination, there's a controversy because HPV vaccination for ages 27 through 45 provides less benefit because most sexually active adults have already been exposed to the HPV vaccine, and that's why you get it at a very young age, starting at age 9. But you know, uh, vaccination does not target all HPV types. Endometrial cancer. Endometrial cancer risks, unopposed estrogen hormone replacement, obesity, diabetes, hypertension. Tamoxifen is twice the risk if you're on tamoxifen. Starting periods at an early age or late menopause, or never have been pregnant or infertility, failure to ovulate, polycystic ovarian syndrome, PCOS, family history of endometrial, breast, or ovarian cancer, and the HNPCC genetic mutation, Lynch syndrome, are risks. Endometrial signs and symptoms. Okay, premenopausal women, okay, abnormal menstruation, alert your provider. Postmenopausal women, bleeding or spotting after menopause, these are warning signs. Report immediately to your healthcare provider, okay? So endometrial recommendations. There's really no screening for the general public, but for high-risk women with like HNPCC genetic mutation and other genetic mutations, you would begin screening at age 35 years. And endometrial biopsy screening is the screening tool of choice every 1 to 2 years. Endometrial cancer prevention. Combined oral contraceptives decrease the unopposed estrogen by adding progesterone. So control obesity, diabetes, hypertension, avoid foods high in fat, and increase physical activity. Ovarian cancer. Ovarian cancer risk factors: inherited genetic mutation, BRCA1 or 2, HNPCC syndrome, risk of ovarian, endometrial, and colon cancer, a family history of ovarian cancer, increasing age, often diagnosed after menopause, never having been pregnant, or hormone replacement therapy, which is controversial. So ovarian cancer is known as the silent whisperer, most lethal gynecologic cancer. There are no screening recommendations for the general public. Your ovaries are located deep within the pelvis, which makes it difficult to diagnose at an early age. Therefore, we need to look at signs and symptoms, and these are signs and symptoms greater than 2 weeks to report: abdominal, pelvic, or low back pain, abdominal bloating, pressure, and fullness, urinary symptoms, urgency, anorexia, and early satiety, GI symptoms, example, indigestion, gas, increased abdominal girth, all of a sudden, like your jeans are too tight, it's a little warning, lack of energy, fatigue. Be aware of these symptoms, ladies. I'm going to go on to skin cancer, and there are different types. There's basal cell cancer to the left, there's squamous cell to the right, okay, and there's malignant melanoma in the bottom. And I'm going to actually, for this lecture, I'm going to talk about malignant melanoma. So personal history, family history, atypical moles, sun sensitivity, history of sunburns, tanning booths, okay, occupational exposure, coal tar, arsenic, and even genetic. Okay. Prevention, avoid excessive sun exposure and apply sunscreen. I am going to talk about the signs of malignant melanoma, the ABCDEs. Okay, and look at this picture. So you see asymmetry. One half mole doesn't match the other. B, border irregularity. Edges are uneven. C, color change, variety of tan, brown, and black. D, diameter greater than 6 millimeters. And E, elevation. And any new skin growth, basically just inform your provider. And this is my presentation. And we'll turn it to genetics.
Thanks, Jennifer. So we have here Becca Wagner and I who are going to be giving the next part of the presentation. And we're going to be talking about hereditary cancer and genetic testing and who should be offered testing, and try to help you all distinguish if you may be a candidate for genetic testing, or perhaps you don't need genetic testing. And so we're going to try to help you to think about your own history and figure that out. And if you decide you need genetic testing, we're happy to see you too. So there's going to be information on how to make that happen. So next. Alrighty. So so I'm going to do the first half of the presentation, and then Becca is going to do the second half. So most cancer, it turns out, is not caused by genetic mutations that can be tested for. So only about 10% we actually call hereditary, because we can identify a mutation or a change in a gene that's inherited that predisposed somebody to developing cancer. There's a significant proportion of cancer, about 25%, where there's still a family history and we don't find any genetic mutation. But we know in certain families there are higher risks, and that could be a combination of genetic factors, but also perhaps shared experiences within families, such as lifestyle, environmental exposures, and other factors. So we'd see this clustering, but we don't necessarily know why. So we call that familial. And then the remainder of cancer cases is sporadic, meaning just one case in a family that seems completely unrelated to anything else going on in the family. Next. So here are some cancers that are not typically hereditary. So we usually don't do genetic testing for these types of cancers if there's just a single case. For example, cervical cancer, lung, testicular, leukemia, lymphoma, thyroid, or liver. So these are ones that are not really part of a hereditary condition for the most part. However, there are a couple of exceptions. Sometimes we still offer genetic testing if there's a family history of cancer. So if somebody in the audience may have a history of one of these cancers, but then also has a strong family history, then we still may want to see you for genetic testing. Or sometimes, I'm going to explain a little bit about tumor genetics. And sometimes when there's genetic testing done of the tumor, there could be a sign of a possible hereditary mutation. So that's something we're always looking out for as well. So this is a little bit more about how genetics of cancer is studied. So there can be two types of genetic testing in cancer cases. So there can be genetic testing of the tumor, where there's tissue removed from the body, whether it's from biopsy or surgery, that can be tested. And the purpose of that is to help the oncologist choose the right treatment. So treatment can be targeted to any genetic mutations in the tumor that are driving the cancer. And this can be incredibly important for choosing the right therapy or even for a clinical trial. So then the other type of genetic testing, which is the type that Becca and I are describing today, is genetic testing of the blood. And blood testing can be done to test the genes that you inherited. The results of that can help you understand cancer risks, not necessarily just for yourself, but also for family members. And for you as a cancer survivor, this can help you learn more about future cancer risks and adjust your screening plans. And I should mention that this type of testing of the blood, is equivalent to testing of the saliva. So they're both looking at the genes that you were born with. So what are some cancers that could be hereditary? So some of the ones that are important to think about are breast, uterine, colon, stomach, and other gastrointestinal cancers diagnosed under age 50. Additionally, ovarian, pancreatic, male breast cancer at any age, high-grade or metastatic prostate cancer, multiple generations of in the family affected with cancer. Like in this family, you can see lots of breast cancer in 4 generations, as well as prostate and ovarian. This is a pretty strong hereditary family. But if there's a pattern like this, we definitely get concerned about genetics. And then also multiple cancer diagnoses in a single individual. So that also gets concerning for heredity. So if you fit into any of these categories, then you would meet guidelines to do genetic testing. So we would be wanting to see you for blood testing. So I'm going to do a couple more slides here, and Becca, just jump in when you think it's time. I think I'm just going to BRCA. So give me a thumbs up if I'm right on that one. Okay. Cool. So BRCA1 and 2, Jennifer mentioned these. These are genes that are associated with hereditary breast and ovarian cancer syndrome. And we all have these genes, just a question of what version we have. If we have a normal version, a normal one from mom and dad, or if we inherited a mutation that increases the risk of developing cancer. And these genes, when somebody has a mutation, one of them causes an increased risk for breast and ovarian cancer. Those are the primary ones that are involved, but also increased risk for pancreatic, prostate, and male breast cancer, and to a lesser degree, skin melanoma. So when Jennifer was talking about genetics of melanoma, this is one that can be related, or two, I should say. Next. So some of the recommendations are incredibly important. So it's to find somebody who has a mutation carrier, who's a mutation carrying BRCA1 or 2. We can offer a lot for screening and prevention, including more frequent breast screening, beginning breast screening at a younger age, like the 25-year-old age, and actually offering MRI instead of just a mammogram. So those are the ways that we can expand screening. So the frequency, the age of starting it, as well as the type of screening that's being done. And then for female mutation carriers, we talk about preventive surgery as well as an option. So somebody who has a very high risk of breast cancer can consider risk-reducing mastectomy, and then a high risk of ovarian cancer, someone consider risk-reducing oophorectomy, or having the ovaries taken out. Okay, now I'm going to hand over to Becca, and she's going to walk us through the rest of the genetics.
Hi, everyone. So I'll first be speaking about another hereditary cancer condition, and this is one of the more common ones that we see, just like the hereditary breast and ovarian cancer that Julie discussed, and this is called Lynch syndrome. This has also been referred to as HNPCC, or hereditary non-polyposis colorectal cancer, which is what Jennifer had referred to it as. This condition is caused by mutation in one of 5 different genes. And individuals with Lynch syndrome have increased risks for colon cancer, endometrial cancer, and ovarian cancer, in addition to some other cancers as well, such as stomach, pancreas, and urinary tract cancers. So individuals with Lynch syndrome, we really recommend screening colonoscopies starting at a younger age and higher frequency. And this is really, really important for colorectal cancer risk reduction, because those precancerous polyps are removed in that process. Upper endoscopy screening is also recommended in conjunction with colonoscopy usually, which is not usually offered in the general population for screening for stomach cancer. Just as Julie had mentioned, for ovarian cancer, we really focus on risk reduction there with preventative surgery. There can be some screening that can be discussed for endometrial cancer as well, but the main focus really is on risk-reducing surgery for these individuals. So you may be wondering at this point, should you have genetic testing done? So to review, anybody who has been diagnosed with ovarian or pancreatic cancer could certainly consider genetic testing. Anybody with an early onset considered adult cancer, so that would be like breast cancer, colorectal, or other gastrointestinal cancer, or uterine cancer diagnosed at a very young age, so under 50 years old, or anybody with metastatic or more aggressive prostate cancer. Even if you've never had cancer and you have a family history of any of those cancers, maybe in a parent or aunt or uncle or sibling, you could certainly consider genetic testing as well. So when you meet with a genetic counselor like Julie, Jacob, and I to talk about genetic testing, there's a couple things that happen. So first, we like to meet with you and assess your medical history and family history as well, and try to understand why you want to undergo genetic testing. We also offer some education on cancer genetics and risks associated with certain genetic mutations. And then we go over the risks, benefits, and limitations to genetic testing and make sure to obtain informed consent. Then once your genetic testing is complete and we have the results, we call you with them and go over what the results mean in the context of the family history. If they're positive, meaning a mutation was found, or negative, meaning no mutation was found, but you still have a strong family history, there's some certain screening recommendations we may still give based on that information. And then we could also offer some genetic testing to family members as well. So we typically test for these genetic conditions on a large panel, so covering up to 85 different genes associated with different forms of hereditary cancer. You can see some of the genes that we've already discussed, such as BRCA1 and 2, and the genes associated with Lynch syndrome. But as you can see, there's also many other genes associated with hereditary cancer, including the genes like ATM, PALB2, associated with hereditary breast cancer, and some of the more rare genetic conditions as well. So the good news is that most insurance payers cover genetic testing. However, each insurance company has a specific criteria to be met to guarantee coverage, and usually that's based on having a strong family history or personal history of cancer. Of course, there's a caveat that there could be copays applicable depending on your specific insurance provider. There's also many labs offer self-pay options that cap out at $250. So this is a great option if there's a high out-of-pocket cost associated with insurance coverage, or if your insurance won't cover the test. It's important to remember that genetic testing not only has implications for you, but your entire family. So if you do undergo genetic testing and you are found to carry a genetic mutation, your other family members are also at risk of having this mutation. So it would be helpful to consider how you would address this with the family and notify them if this were the case. But also really important too is getting the family history information from your relatives. That could really impact whether we, would consider genetic testing or not, depending on the specific diagnosis and at what age they developed cancer. So just to summarize our genetics talk, only a small fraction, 5 to 10% of all cancer is hereditary or inherited. Certain types of cancer are more frequently associated with hereditary syndromes, such as those we discussed, like hereditary breast and ovarian cancer and hereditary colorectal cancer. Genetic test results can be really important and influence cancer screening and prevention. And genetic counseling and evaluation is an important tool in cancer prevention for cancer survivors and their family members. And knowing the family history can be very, very valuable during these sessions. So now I'll pass it on over back to Julie and Jacob to discuss some emerging topics.
Thanks, Becca. So Jacob, do you want to lead us off here or just go over the topics?
Yeah, sure. So Julie will start by talking about direct-to-consumer imaging, and then I'll follow up with some exciting new tests that are sort of starting to come to market, liquid biopsy for early cancer detection.
So one of the reasons that we wanted to include this section, and Dr. Fryer was saying that sometimes it's helpful to have kind of an overview of what are some of the screening techniques that you just might hear about, like maybe you hear about them in the news, or maybe someone tells you about them, and maybe this could be something that you consider doing but don't really know a lot about. So we wanted to educate you to on some of these screening tests that may not be standard of care right now, but that may be something to think about, or perhaps even think about and not do, but at least get more knowledge and information. So, so the first one we're going to talk about is whole body MRI, and so just to start off, whole body MRI is definitely not a standard of care. It is only a standard of care for an extremely rare genetic condition called Li-Fraumeni syndrome. And for people who have that syndrome, there is a general consensus that that is recommended, but very few people have that syndrome. There are a lot of people who are concerned that there could be some cancer somewhere in their body. And so one thing that we wanted to do is tell you a little bit about some of these screening tests, and they're even offered directly to consumers, like outside of your USC care or care out in your regular doctor's office. So we got some advice from our radiologist at USC, so we wanted to go over that with you. So MRI technology and procedures, first of all, can vary widely. So the whole body MRI or the MRI technology that you may have had as part of your cancer care or may have had at Keck may not be of the same quality when it is done outside. It may or may not. So that's one of the things to look into, is trying to understand how good of an MRI one would get. And a whole body MRI is actually a screening test. It's not really a dedicated scan of a certain body part, like probably the MRIs that some of you may have had. As a screening test, there is a possibility that something could light up, which is a false positive. And so once an abnormality is detected, an MRI of that organ is usually ordered. So there's just a consideration that when having a screening test, it's possible you may be going down a road of having to have more and more tests. So something to keep in mind. Next. So let's talk about cost. So insurance does not cover the cost of whole body MRI. Even for that rare syndrome that I talked about, we still are battling insurance companies. And so some of the sums available could be exceedingly high, even like $2,500 to get a whole body MRI. Another consideration is that getting this sort of test is only a snapshot in time, and it has to be repeated yearly. So to be thorough. So there could be a recurring cost. So if you decide this is something you want to do, keep in mind that you might get a negative test, you have peace of mind this year, but then you may have to continue spending that much money to have that peace of mind every year. There are also another consideration is that some of the more common cancers, like Jennifer mentioned at the beginning, like colon, breast, prostate, etc., they have their own screening tests. So it's ideal to do those screening tests, which are more sensitive and more likely to detect cancer if it's there. For example, getting a mammogram for breast cancer screening. So whole body MRI doesn't replace those screening tests. And then, so, and that just is the very most important thing to consider is that regular examination, physical checkups are really essential. So you can't just rely on the whole body MRI. So in conclusion, MRIs can be expensive, may have to be repeated, may have false positives, and you still need to be vigilant. So, so this is one of the things to consider when considering whether to have a whole body MRI or not.
Thanks, Julie. So we'll sort of shift gears and talk about liquid biopsy for early cancer detection. And just as a quick review of some of the topics that Jennifer had discussed, we currently have population screening options for the following cancers, which are colored on this diagram. So breast cancer, as was mentioned, lung cancer, colon cancer, prostate cancer, and cervical cancer. But most cancer types currently we don't really have screening options for, including all the ones grayed out and those beyond those shown here as well. Next slide, please. So some challenges of some of the current screening options, as important as they are that they are not available for most cancer types, as I just mentioned. In some cases, they may involve invasive techniques and radiation exposure or preparation that many people don't find very pleasant. That's, I guess, sort of the next bullet there, but there's inconvenience in preparation for the screening as well. And then there can be as with any screening test, false positives that require further follow-up. Next, please. So something that's used now for and FDA approved for patients with cancer is something called a liquid biopsy. Just to turn your attention towards the diagram here to the right, we know that sometimes when there's a tumor in the body, it can shed sometimes DNA into the blood, other protein biomarkers. And so some very smart scientists have developed tests where they can actually look at some of the cell-free DNA that's been shed from tumors to help assess prognosis, treatment response, i.e. which chemotherapies and even immunotherapies may be most effective, and also to monitor disease recurrence, sometimes progression. So there are some, and I'll sort of talk about the serendipitous discovery of one of these tests that's coming to market, but there are multi-cancer early detection tests which sort of harness this technology that's been used for cancer patients in the hopes that we can actually screen asymptomatic individuals in the population to look for cancer signals in the blood. And the hope there is to detect cancers at an early stage, or just in general identify cancers that are not currently available to screen for. As an interesting aside, and as I mentioned, the serendipity of this discovery was actually, they used a similar technology for pregnant women to determine sometimes whether there may be some chromosomal abnormalities with the fetus. And they look at some of the fetal DNA that's circulating in the mother's blood to make sure that the ratios are proper there. And one of the companies used that technology and figured, well, why can't we use a similar technology to look to see whether or not there might be cancer signals indicative that there could be a cancer elsewhere in the body. Next slide, please. So that company you may have heard about, it's gotten some press, it's Grail, and they offer this Gallery test, which is actually the only current clinically available test, although there's many in development. But as you can see here, this is sort of the model of their testing, and it's a screening test, of course, but they do harness this sort of liquid biopsy. The tumor sheds DNA into the bloodstream, and they're able to, with a simple blood draw, sort of isolate the tumor DNA and use some proprietary analysis of some of the DNA signatures, and then some further technology that basically allows them to determine whether or not there might be a cancer signal. If there is a cancer signal, they are able to look at the analysis of those DNA signatures to determine the tissue of origin, and that may prompt further workup for these patients who screen positive on this screening test. Next, please. So it's very important to realize with this technology, first of all, that it is in development, and secondly, that the sensitivity is not so high. What that means is that if someone has cancer, what is the ability of the screening test to determine, for the test to tell that that patient is positive, that they screen positive? The specificity, fortunately, is fairly high, meaning that those who test, it can properly say that someone's negative, essentially. So there's not a whole lot of false positives, so to speak. So it's not coming back saying that a lot of people have cancer when really they don't, because that could be sort of alarming. But I think what's sort of lacking right now that they're, I think, trying to improve is the sensitivity of the testing. So as you can see across different cancer types, thyroid cancer and prostate cancer, for instance, the sensitivity, so the ability to detect these cancers in the individuals who have them, and for those individuals to test positive, is fairly low. But as you go to other sort of cancer types, you can see that the sensitivity is higher. So it really, there's a large spectrum. The other cool thing here is that you can see some of the cancers that the liquid biopsy can actually screen for. And some companies like the one I just mentioned can detect close to 50 different cancer types with a single blood draw. I think there might be an animation, so hit next, please. So prostate and breast, you can see here prostate cancer sensitivity is only 11% versus breast is 30.5%. And I just wanted to highlight those because, you know, it's important that for the current population screening that people are still getting those screenings, especially given the relatively low sensitivity of this screening option. Okay, next, please. So, and when you start sort of aggregating all the cancer classes, the sensitivity of this test right now is just about around 50% for all cancer types. When you start to look at 12 cancers that account for most of the US deaths, including some of those that currently have screening options, you know, you can get that sensitivity a bit higher, up to 76.3%. And you can see some of those cancers listed there. Next slide, please. And I think what's really important to realize about this test is that it varies. The success of this test at detecting cancers early on varies by clinical stage, which is sort of intuitive if you think about it. If you have an advanced cancer that's spread in the body, it's shedding more tumor DNA. There are more signatures that can be picked up. But less than 20% of stage 1 cancers overall are being detected with this liquid biopsy. And obviously, the goal is to really detect cancers early on when they're most treatable and when there are the best outcomes. So I think there's a long way to go there as well. You know, unfortunately, stage 4 is currently the most, the sensitivity is highest for stage 4 cancers. Next, please. So just to outline some of the benefits, it's a simple blood draw. I think that's what's appealing to most people. There's a relatively low false positive rate, as I mentioned, with the specificity. You can screen for many cancers. Some companies and tests that are being developed up to 50 at once, and a lot of these don't have current screening options, so that's really appealing as well. With they're usually able to determine the tissue of origin pretty well based on those signatures that are found. And they can preferentially detect cancers that are clinically significant. Next, please. Some limitations to the liquid biopsy. First, you know, NCI and others have acknowledged the fact that there's a long way to go with the development of these tests, but they're really not optimized to catch cancers early on and before they spread. You can see, as I mentioned, that the stage 1 cancers overall, the detection sensitivity is less than 20%. And that's based on cancer type and stage. Also cost, and with this comes a discussion of healthcare disparities. We know that it costs probably around $950 right now. Prescriptions needed. It's not likely to be covered by insurance, and it's not covered by Medicare. As I mentioned, this could create healthcare disparities. We don't know if the test works equally well across all different ethnicities and backgrounds, and whether it's optimized for certain patient populations either. There's currently one test available, and it's not actually FDA approved. It's gotten FDA breakthrough therapy designation, but there's multiple other competing developers who are seeking FDA approval. We don't always know the origin of cancer, and you can imagine that it might be sort of not so helpful if someone screens positive on a liquid biopsy for early cancer detection screening tests and they can't find a cancer. And then you're left wondering, okay, well, am I at increased risk for cancer in the future? Do I need to come back for screening? Do I need further workup? And that can create anxiety. And there's, it's not recommended for those who are younger than 21, pregnant women, or those who are undergoing cancer treatment. And it may be something that needs to be repeated over time. Next, please. So, as Julie mentioned, there are direct-to-consumer whole-body MRI options, but the technologies vary and costs are a major limitation. Liquid biopsy for early cancer detection is promising and honestly very interesting. And it's a new screening test that can detect many different cancer types with a simple blood draw. But it is still in development, and we do hope that there will be improvements in the future. Thank you. So, oh, yeah, sorry. That was a quick snapshot of our genetics team. We are fortunate to have some colleagues who work at the Los Angeles General location. And then there's 4 of us here at USC Norris. There's our contact information, and then feel free to advance. Yeah.
I'm sorry. I was just, hold on. Let me get hello, everybody. I'm Ora Cooperberg, and I just want to say how fascinating this workshop was, but I just wanted to mention that kind of part of our whole AYA at USC and the program for young adults, adolescents and young adults with cancer, and the cancer survivorship program, we have our AYA at USC programs. And could you just, and part of that is connecting young adults with a supportive AYA community. Could we change this one more time? I just wanted to introduce you to our amazing team. And by the way, Dr. Fryer is on this team too. He wears many, many hats. And Dr. Hu, Elaine Vieira, and Mario Espicia, Ora, myself, and Shu. And we're really, like I said, really lucky to have such a wonderful team serving. And these are these are adolescents and young adults that are on treatment or before they go to the survivorship program. Next one, please. And this is the different things that everybody does. We have the social worker, the clinical care, with the nurse navigator, research, education, community outreach, and of course our supportive programming, which is open for patients and survivors. So we really are able to serve a very broad number, a very big number, and a broad age range. Next, please. I love to describe this concept of a third space home. This third space, unlike home, which is a first space, or work or education, that's a second space, this is a third space. Unfortunately, it is just a conceptual framework, but in it, that's where we house all our programs, our education, our peer building engagement programs, our empowerment programs with self-expression and wellness, and our leadership with our the development of our AYA Council. And through these programs, we're able to really address the entire person. And like I said, we invite patients and survivors, caregivers, and even healthcare professionals, because we do have such wonderful and special workshops that are open to everybody. Thank you. And these are some of our photos. It's always great to have photos that say more than words. We have our signature 3-day retreat and many other peer enhancing connection programs throughout the year. And like I said, very interesting workshops, self-expression and wellness workshops, as well as ones that really teach our young adults about their cancer and how to cope. And is there another? Okay, and this is how you can contact all of us. We have, like I said, there's the Adolescent and Young Adult Cancer Program at USC, and that's the patient care. If anybody wants to contact us, you can be put on we can get our newsletter. And then if you need follow-up care, there's or you need to be referred, there's a USC Norris coordinator and scheduler. And of course, today, it was brought to you today, the wonderful workshop by our Cancer Survivorship Program. And I see here that Jennifer Solomon's number is, an email is listed. So thank you. And hopefully, like I said, I'd like to encourage anyone to reach out if you are in need of any or want to learn more about any of these programs or be put on our newsletter. Thank you.